So Fernando, thank you again. I have to beg your pardon because I wasn't able, having received the slides, the template so far, I put just in the first one. Is it okay for you? Okay. Second thing, yeah, I'm anticipating a little bit what we are discussing tomorrow, which is drug-coated balloons. So obviously I put also some cases with a good lesion preparation, which is of such a paramount importance with DCB, like for stents, for sure, but not the first one. The first one is a very interesting case, in my opinion. I was proctoring in a center in Asia when a very young patient came with STEMI, okay? He came with an inferior STEMI, and obviously, the operator decided to do some thrombus aspiration, and so this was the result after thrombus aspiration. So he was asking the stent, so I said, why? I'm here, so let's try with a different approach. And that's what we did. So we started ballooning the lesion with a 2.5 by 15 balloon. This is not a calcific lesion, it's different from what we have seen so far, but we decided to go a little bit further with an improved lesion preparation. And so this is what we did with a soft, very slow inflation. This is what we should do in a soft plaque like this one in order to avoid big dissections. We like dissections. Tomorrow we will see which is the outcome of dissections left after DCB, but we want to avoid the large dissections with an impaired flow. So we went with this 3.0 balloon and then we assessed it. Look, it's like a stent. It's a very nice. So at this stage, we decided to deliver the drug, and this is what we did. We used one single, very long sirolimus-coated balloon. And this was the final result. So I don't know, maybe there is a type A or no. Maybe if you do imaging, you will find some dissection, but it's not angiographically. Yes, there is some dissection here, but it's a very good result. So in this young patient, we are so happy not having put any metal, because this is a 37-year-old patient. We have seen that from your study, after 10 years, we have a 43% of cases of TLF, 43% with currently available stents. With this device, you may have restenosis, but if you have it, you will have it in the first months, the first 18 months, I would say, from the data that we have, not after that. So this is one straightforward, easy case showing the concept of lesion preparation and using, in the end, something that is different from what you have in mind, which is, okay, open me some metal, open me a stent. But now let's pass to other cases. This is a 49-year-old ACS patient with a diffuse disease. This is a topic that, if I remember well, Patrick will present tomorrow on the role of DCB. So again, we prepared it, in this case, with non-compliant balloons, 3.0 by 25. Then we use another, after good lesion preparation, another two different DCB. We can use the longer, the better, differentiated from stents. And this was the result after, not lesion preparation, but after the final treatment. There is here quite clearly a dissection, but the flow was good. So what did we do? We waited for some time, 10 minutes. Then we checked again from another view, and this is what we obtained. So sometimes this aerial view of the right coronary artery after stenting also, but mostly after DCB, is showing some huge dissection or some good recoil. Not in this case, so ciao. So we decided to end it up, and then the patient came back after 10 months, and look at how nicely this DCB PCI was healed after the dissection. Obviously, also, I will show this tomorrow. I don't want to spoil my presentation of tomorrow, but also POBA after dissection healed, but they heal in a different way. In this case, we were so happy to leave it like this, and this is the outcome that we obtained after 10 months. But now let's go to a more, calcific lesion in older patients. This patient had this nice calcification in the proximal part of the LAD and in a diffuse disease setting. Unfortunately, the IFR was positive for the proximal LAD, so we had to manage it. We did the OCT, and we found a calcific nodule. So like we said before, the problem with the intravascular lithotripsy is the crossing profile. it's not only the profile, but the deliverability of the device, which is not optimal. We were not able to cross this bending. Angiographically, the lesion was not 90%, okay? But there was a calcific nodule and the bending. So we were not able to cross with lithotripsy, okay? Then we predilated it and we used the rota just to create some more cracks. From our experience, rota is not just doing the hole which is correlated to the sides of the bar. It's not creating only a hole of 1.5 because it's rotating, it's creating also some nice cracks into the calcium. And then we use a predilatation balloon. And then in the end, we were able to use the IVL, 3/12. We use it, I don't remember, 4 and 4 or something like that. And that was the final result after lesion preparation. We assessed it in another projection. Let's just start. Yeah. And it was a good lesion preparation. So why not using a DCB also here, also in a highly calcific lesion? And this was, that was the result, and this was the result after 13 months. Sorry for this. Can you repeat it again, please? After angiographic follow-up, more than 1 year follow-up with very good, yeah, I'm moving it, with a very good outcome without restenosis. So there is a growing experience of plaque modification tools, meaning a rotablator, but also shockwave, like in this one, showing how the performance of these devices for lesion preparation is good also for drug-coated balloons. Obviously, we don't have data. There is, I would say, also paucity of data also for before stenting, but the experience, you know, it's very nice also with this angiographic follow-up. Now we are not doing any more angiographic follow-up in this type of patients because we have seen that it's a safe tool. Yeah, so I had also other cases, but I cut it because you know, I would like to stimulate the discussion. Some of them were quite provocative if you are not experienced with DCB. So please let me know which is your ideas and your experience on this. Would you use a DCB leaving such a dissection like for the second case? Would you use a DCB in the STEMI cases like the first one? Now we have some data, Revelation trial done by Nicole Voss and company at OLVG is showing a very good outcome. They told me that now they are gathering also the information with a 5-year follow-up, which maintains the good performance also already shown in the 3-year follow-up. So I think now we have some data for using DCB also in different settings. But please, it's up to you.
Another great cases. So I have a long experience with PCA, PTCA and bare metal stents and drug-eluting stents. Our concern was always the dissection for subacute occlusion. That was, and for that we used, you don't know probably, but perfusion balloon. Yeah. So I
read it in some books.
Yeah. We left the balloon there for half an hour.
Yeah.
And just because we are concerned with that. So DCB is not helping for this, for sure, because this is acute result. DCB may help for the future results, for the long-term outcomes. But the risk of a dissection is not modified by the use of DCB. The risk, immediate risk or acute risk. I think that we have advanced in another direction. Our antiplatelet therapy allows us to be much more tolerant to this dissection, for this dissection. This is what we have achieved and what we didn't have before. You don't know, stenting was born as a bailout procedure just for these cases.
Yeah, that I know, but after...
And this is just to remember, and that's why I always say the theory is not enough. You can destroy mountains with pictures, but what is meaning that for the future of the patient, you don't know. What we presume, maybe everything is wrong. For example, if we try to achieve 100% result, an optimal result, 0% residual stenosis, it's okay, we are happy, we go sleep very happy with that. But what is that meaning for the patient? We don't know. all the trials are very small trials. We are obliged to use surrogate endpoints in order to show something with 30 patients, 50 patients. And we show some acute results, which support our hypothesis. But the problem, we don't know what is the relevance in the future for this. That's why we need always randomized trials with important number, with a sufficient number of patients.
Yeah.
Even for IVL, I have been struggling with the IVL company for doing a study. No.
Yeah. I'm not surprised.
Yeah. No. And just I tell you a story because stories in my age are very usual. 15 years ago, we met with a stent company with a special coating. I said, we need a randomized trial. No, it's clear. We have shown it in animal. We did this randomized trial 3 years ago. Nothing at all.
Yeah, okay. I don't want, as I said before, to spoil my 3 presentations of tomorrow. One is on small vessels and angiographic outcome, the other one on the very long-term outcome of DCB, and the third one is on dissections, okay? So I'm not telling you about this. I'm telling you that I did my first DCB PCI just after the publication of PACOCA trial by Bruno, 2007, okay? And then I struggled for more than 10 years in order to convince DCB, meaning paclitaxel DCB companies, to do a big study. In the end, B. Brown was able to do the Basket Small 2, which is a big study, 700 patients, not a huge one, but it had to come a sirolimus coated balloon company, well, 2 of them actually, who had, the braveness of doing a properly sized study with more than 1,000 patients randomized with a clinical endpoint, okay? So now we are discussing about surrogate endpoint, very long term follow-up, and some clinical endpoints which are coming later. But yeah, I agree with you that we need randomized trials. It is a pity that it took 15 years before having some companies that wanted to invest on this.
But it's clear we should not have the fear of years ago for dissections. This is clear. This is due to our better antiplatelet therapy.
But no, for this I don't agree, because we have a huge experience of living dissections with DCB. Now we know, we are doing, the DCB arc. We know when to leave a dissection. In my experience with more than 2,000 PCIs with DCB in native vessel disease, I only had 1 case of acute occlusion after a few hours.
What kind of antiplatelet therapy are you using? It has not to do with DCB.
Yeah, no, that was a patient with a dual antiplatelet therapy, 2015 or 16. At that time, we always prepare the patients before coming, also the elective patients. But in that case, I left the dissection. I didn't do the second orthogonal view, and the patient had a 90% recoil, only in that view. And then he had an occlusion. That was the only case. So now we do it routinely since 2016 in all of the patients, 1 and 2. The second one after 10 minutes, 7 minutes, whatever it is. In terms of antiplatelet therapy, I think I had a long discussion, and he was on my side for this, with Marco Valgimigli, and we believe that to prevent the acute occlusion, you don't need a strong antiplatelet. You need a good anticoagulant, maybe for some time, for 24 hours, 72 hours, whatever it is, but not too strong antiplatelets or a strong antiplatelet. This is my belief, but again, I don't have data. I only have some data with a single antiplatelet therapy after DCB, but I will present tomorrow.
So that means that our antithrombotic therapy is better now. This is for sure than before.
Panelists.
Thank you, Bernardo. Nice presentation. So I just wanted to hear your comments or your feelings, since we don't have much data, about STEMI patients. What are your feelings? You show a beautiful case, but are you recommending that on the clinical practice just regularly for young patients? Straight lesions, no bifurcations? Which kind of lesions, which kind of STEMI patients are you recommending? What are your thoughts on STEMI?
I can reply to you also if you ask me the same question with a calcific lesion, which is you should prepare the lesion and decide. In this case, we had a good lesion preparation, use the DCB. If you had a big dissection, use a stent. So this can be said for STEMI, for calcific lesions, for any type of lesions. you have to prepare it. Now we have a lot of tools for doing it. Sometimes, sometimes we decide before because we want to use a DCB. In this case, we go with a stepwise approach with a balloon. Usually I go with a 0.75 to 1 ratio, and then I go with an increase. It takes a little bit more time, and it's more time consuming doing a DCB PCI. And then we have a bad result. But again, for example, this is a high bleeding risk patient. We want to use a DCB. We use a larger balloon. We keep it inflated for 20 seconds, angina. We deflate it, we wait, and then again 30 seconds, with a sort of preconditioning. This is what we do regularly. But normally, if you are, unbiased on using whatever you want, you should prepare the lesion and then decide after lesion preparation.
A nice presentation. I would like to act, as we say in Spain, as the devil lawyer. So if you really think that DCB are as good as current stents or even better, and many of the problems that we see with the stent are during follow-up with issues regarding underexpansion, malapposition, and all that things that should not occur with DCBs. Why don't we treat lesions such as left main with DCBs?
Okay, the acute occlusion of left main is not a case where the patient is coming back for a stenosis. Okay, so that patient would probably die with a sudden death. Huh?
So you are not so confident?
No, I'm not confident in using it there because we need to have data for the left main because prognostically it's dead or alive. Okay, it's not TLR. Okay. We are sure that DCB, we used in the proximal LAD here, but we have done a lot of cases in the proximal LAD. If we have a good lesion preparation, if we have imaging, because this is the other problem, we didn't discuss about this also in the previous session, we need to have imaging in in the calcific lesions, imaging 100%, heavily calcific lesions. Also because it's not easy to understand if it's a highly calcific lesions or not. Because you see big calcification, but it's an adventitial calcification, nobody cares about it, because you need to interpret and treat the calcification in the intima and intermedia, okay, which is prognostically relevant. So imaging is an important tool. So you can use DCB. We have used DCB for left main sporadically when we didn't want, for example, for trifurcation, quadrifurcation, or for ISR of a stent previously implanted in the left main. But I would not suggest to use a DCB now, today, for the left main as a primary treatment.
I think, Bernardo, you have to add some advantage to your slides, is the protection of small side branches with balloon-only based stenting, which is a problem with stenting.
Yeah.
We see it. We see it also with the elevation of biomarkers, which is very small branches. We don't see in angio probably, but balloon is much better for that. And this is also to show that the acute result is not everything. This philosophy of using only balloons, DCB or other things, is also something that shows that the acute results, which are for sure optimal with stent, are not
immediately.
Yeah.
I agree with you, obviously. And this is a clever point because I was discussing in the same session with Fernando at EuroPCR last week. In the end of the session, I was very provocative because this EuroPCR was rich of sessions with DCB. Okay? Interest is growing a lot. You can see, you can perceive it. But I saw 2 live cases from 2 very experienced centers doing still chemin de fer without any reason, putting a stent from the proximal LAD to the distal LAD. And you know how rich is the LAD of side branches, septal branches that will occlude at some point with the stent.
But that's the reason
Antonio.
why I believe when you go to outside small vessels, we should do as an endpoint troponin, because when you treat long LAD, you're always going to have troponin increase. But if you do stenting, quantitatively will be much higher.
Antonio, we have a very large series of patients with follow-up angiography.
With follow-up angiography.
And during follow-up angiography, we have also done left ventricular angiography. Excellent results at follow-up for the vessel. And ejection fraction going down.
With
What is the reason there?
that with
Exactly
stents
this.
or with balloon?
With stents, with stents.
With stents. Oh, yeah.
You have
that's
to publish this
but
data.
that's the reason why you close the
important
small
data.
branches that you don't see.
We are working on it.
You
We have
close
very
the small
large
branches.
and this is the, and it should be added to your.
Yeah, but these were just cases. Yeah.
No, no,
Thank you.
So, okay, we are a little bit late, so let's go with the next case that will be presented by David Derbal from Hospital La Princesa in Madrid.
Thank you very much and welcome everybody to La Princesa Hospital. It's a pleasure for us to participate in this great meeting. So we want to share with you an interesting cases from our center that we have entitled an unexpected dance partner, and you will see why in the next few minutes. So this is a 65-year-old gentleman with a cardiovascular risk factor, hypertension, dyslipidemia. He's an active smoker, and he was on aspirin, beta blocker, the treatment for hypertension, and statins. And he had a long history of coronary artery disease that started in 2006 with a stable angina. And that's why he underwent a PCI in the right coronary artery with implantation of drug-eluting stent. The patient was completely asymptomatic during the follow-up, but 1 month ago, the patient started with chest pain and ST elevation, segment elevation in the inferior leads, and the patient was transferred to our institution for a primary PCI. So here I present you the anatomy. So as you can observe, he had a mild and diffuse coronary artery disease in the left LAD and circumflex with no significant lesions. And this was the culprit vessel. You can identify here the stent that was implanted in 2006 and with an acute occlusion. So this was our first strategy. We start with a 6-French guiding catheter and a guide extension catheter. We use a Sesión blood guide wire that successfully crossed the lesion. But after several attempts or advanced very small balloons, we were not able to cross the distal part of the stents. So therefore we replaced the Sesión blood with a higher support guide wire. And finally we achieved to advance a very small balloon, 0.75, and we perform a progressive dilation with a semi-compliant, non-compliant, and scoring balloon. And here are some images to see more in detail the case. So the patient had a diffuse stent restenosis with a critical stenosis in the distal portion of the stents. We perform a progressive dilation with semi-compliant, non-compliant, and scoring balloons, and this was the angiographic result after this dilation. But as you can see here, despite all the dilation with high pressure balloons, there was not a proper lesion expansion, and there were always a risk in the balloons. So at this point, we decided to perform intravascular imaging, OCT, to better understand the underlying cause of the in-stent restenosis and also to rule out some mechanical complication of the stents. And here you are the complete pullback from the distal to the proximal right coronary artery that we can discuss later. And here you can observe more in detail images. So we can identify, we found some interesting things. The first one is that the stent, there was not a mechanical issue of the stent. The stent, there was a good expansion of the previous implanted stent, but as you can see here, there was a lot of calcium. There was a calcified neoatherosclerosis with areas with a thick calcium and more than 2060 degrees. So this is one of the greatest enemy in the cath lab, and particularly in this situation, in the treatment of in-stent restenosis. So at this point, we decided to be more aggressive with this lesion, and we decided to use some techniques for plaque modification, and in this case, we use IVL. So we use a 3.0 balloon. We give in total 60 pulses, and I show you the result after IVL and after dilation with a high pressure balloon. This is the angiographic result. So at this point, someone can say, okay, maybe with a drug coat balloon will be enough, but we finally decided to cover all the stent restenosis with another stent. So we perform an angioplasty with a drug-eluting stent, a long drug-eluting stent, 3044, and this is the final result. So this is we think that this is a very interesting case for discuss some points. So the first one is, which is your experience, all the panelists, all the audience, what is your experience with the use of IVL for the treatment of the culprit vessel in STEMI? Also, what is your experience with IVL in calcifying stent restenosis? Do you use intracoronary imaging in all the cases of stent failure? Do you prefer IVUS or do you prefer OCT? Which is your first choice technique for these particular cases? Do you prefer IVL, rotational atherectomy, laser? And maybe these cases, the treatment in these cases will be enough with a drug coat balloon, or is you prefer to use a drug-eluting stents in this particular clinical scenario? So we are open for discussion.
Okay, it's a good case, and I think that is the better indication for DCB, a case like this. But I have a question for the panel, for you. Do you change the drug of DCB with the stent before use it, or there are no trial, there are nothing?
So this is a very good question, but the problem is that in 2006 the patient underwent the PCI in a private center. So at this point we have not much information about the stent that they use it. So honestly, we don't know if we change the drug or we use the same drug in this case.
I think that the drug is not an issue because for Cypher it's eluted the first months. Okay. So the problem is not after 15 years, 10 years, 15 years, the issue is not a drug eluted. It's a neoatherosclerosis related to calcifications and then thrombotic occlusion. So I don't think that that's the point. We have few data. Okay, stent is going well for ISR. We have seen by meta-analysis, by Jacopo and other things. I do prefer using a DCB, but I think that in the studies, also in the DR4, this type of ISR was not enrolled.
Yeah.
So these highly calcific, very long lesions, instant restenotic lesions were not enrolled. So honestly, I would use a DCB also because probably you can have another restenosis, but it will be much easier to be treated instead of a restenosis of a second layer of stent with a calcium in the middle.
But I think you did a good job, no question. The problem is that these diffuse in-stent restenosis, they always come back.
Yeah.
So I mean, it's only, the only way to prevent recurrence is to don't do follow-up. But they always come back, always. So honestly, when I see these, unless there is a real strong clinical indication, I prefer medical therapy, because they are a failure of angioplasty. Technically, one procedure that if you don't have lithotripsy, that works very well is laser with contrast. When you have these calcific that you cannot cross laser with contrast, if you have laser, not many laboratories, is very effective. But the problem, you did an excellent job, but the problem is that it's so depressing because they always come back.
So perhaps we won't do the follow-up in this patient. No, the reason why David selected this case is first because there is the use of IBL in STEMI, which is not very common as rotational atherectomy. This is rare. But more importantly, I mean, what would be the case of this, the cause of this STEMI? I mean, there is clear calcify in stent restenosis. We know that from our own series that this is occurring in up to 15% of the cases. You know, all patients, long time from stent implantation to in stent restenosis, hemodialysis, many things. But in most of these cases, the presentation is stable. So here, you can imagine that perhaps there is a calcified nodule within the calcified neoatherosclerosis that is causing the rupture and then the STEMI. Or alternatively, you can think that there is progressive narrowing in just the patient presented with STEMI. But this is unique. I mean, this is not the typical neoatherosclerosis when a soft, lipid-rich plaque ruptures and you get STEMI. This is calcified neoatherosclerosis presenting as a STEMI. So I think this is why we consider this of interest.
I'm sorry. Oh, no, please go ahead. I have a question for Fernando later.
No, excellent case and excellent result. So only I want to say that remark the importance of the intracoronary imaging in these cases, not only in a STEMI patient, but in patients with stent failure, especially in restenosis. In stent restenosis, it's very, very important to do an intracoronary imaging, and OCT, of course, offer us an imaging with we can study the substrate of the restenosis, and we can prepare the lesion adequate, because in this case we saw and we observed neoatherosclerosis, calcified neoatherosclerosis, and probably change your next device in order to treat the lesion.
But you know, I want to be a little bit provocative. I like imaging, but honestly, how the imaging would have changed your strategy here? If nothing goes forward, you have to use a rotablator or something like that. You have to go forward. So, I mean, you know, it's nice imaging. We always talk imaging is important, but before doing imaging, we have to ask our question. If I find A, I will do B. If I find B, I will do C. But at the end, you do the same.
Yeah. Fernando, I would like to be more speculative and know your opinion on this. So this patient had a very nice left coronary system. Obviously, we don't have imaging for that, but it doesn't seem that there is a lot of calcium. Then we have a stent implanted 20 years ago with a lot of calcium in it. So which can be our conclusion? Why all of the calcium of these patients was able to go just in that neoatherosclerosis and not everywhere?
Easy answer, we don't know. We don't know. I mean, I just forgot to explain that one of the reasons to have in-stent neoatherosclerosis, which is calcified, is that the artery is heavily calcified. And there are some cases also where a calcified nodule can grow within the stent, which is different from the typical pattern of neoatherosclerosis, which is rather smooth, not protruding. But why in this patient all the calcium went to the right, I don't know.
Not the right, in the stent.
In the stent.
You know, the Bernardo, the disease goes there because the artery was already diseased. You place a stent because there was something there. So even if you did the drug-coated balloon 10 years or 5 years before, the problem is the disease. The artery is sick in that area, and whatever you use, DCB, stent, you don't cure the sickness of the vessel.
You also may provoke.
You know, in the old time, there is an old paper of Dr. Prati, I am a co-author, but in the time of bare metastent, one of the most important predictors of recurrence was the amount of plaque behind the stent. So it means that if the vessel is diseased, even if you place a stent or whatever, you make the lumen large, the disease stays there.
I have another question. Fernando, you are one of the most experienced physicians on ISR. In your experience, which is the percentage of calcific ISR in an ISR occurring after 1 year and in ISR occurring after 10 years? So, no, I want to understand. This is very important for us because we are implanting stents everywhere to a lot of patients. Is there an increase in the transformation of neoatherosclerosis into a calcific neuroatherosclerosis within the years? Probably more than in a normal process of atherosclerosis. This is the question that I have. Probably you don't have an answer, but it's a question.
I mean, Marcos Garcia Guimaraes, when he was with us, did this study when we compare calcified neoatherosclerosis with non-calcified neoatherosclerosis, I would say classical lipid-laden neoatherosclerosis, and neointimal pattern in stent restenosis. And the time elapsed from stent implantation to in stent restenosis was much larger, was significantly larger in patients with calcified neoatherosclerosis. Having said that, that was a very small series. So this is what I can say. This is a factor.
Turn away from DCB for a moment. I would like to ask from a more, congratulations for the case, David, it's very well managed, but I would like to know from a more technical point of view, why leaving 10 pulse left with the shockwave? Why did you only deliver 70 pulses and not 80?
That's a good question. I think that 10 pulses plus, 10 pulses more, maybe didn't change the result. So there was enough. We performed 17 total all along the stent, and 10 more, 10 less. I think in
my practice, I tend to. I would like more pulses from the catheter, and one of the most important upgrades that is going to have is, I think, 120 pulses. The catheter with for this kind of lesions may be valuable. So, in my experience, what I think a shockwave is great, and the only cases I would have liked more was when I didn't deliver all the therapies. I think for me it's like a fact. I have to reach 80 if the patient tolerates it, even at 3 a.m.
Sometimes you want to keep 10 or 20 just in case something does happen.
maybe that may be a reason.
Okay, you want to go ahead with the next?
So, we're going to move to the next presentation from Maite Velázquez from Hospital 12 de Octubre in Madrid.
One important thing, additional comment I would like to do outside of DCB and ISR, if you use imaging to assess the lesion, but also to see after shockwave if you have prepared it correctly and if you are ready for a final treatment. So not just, okay, I've used the imaging, I'm okay with my conscience. Please.
Okay, thank you. Good afternoon. Well, first of all, I must say that I don't have very much experience with IVL because in our cath lab, this is a device that we don't have in ourselves, so we have to ask for permission, and because of its cost, so we have to ask for permission, ask for the catheter, and then do a second procedure with this device. So this is the reason, but this is not a case I perform by myself, it's a case of another colleague, but I think that we can extract some teachings and debate about this case. So this is a 72 years old male. He is diabetic, has hypertension. He had a kidney transplant in 2016, and he has nephroangiosclerosis of the donor kidney with creatinine 3.54 milligrams deciliter. In March 2016, he had a pacemaker. He had paroxysmal atrial fibrillation, chronic ischemia with right iliofemoral occlusion, and normal LV function with mild LV dilation. In August 2020, he had a non-stay elevation acute coronary syndrome, and the drug-eluting stent 3/20 was implanted in the mid-LAD. He had a stable situation with angina on severe exertion under medical treatment, but in September 2021 he began with progressive angina, and he came to the hospital because he had a small effort angina. This was his treatment. He had azenocumarol, carvedilol, nitroglycerin, atorvastatin from a cardiology point of view. And this was, I don't know if perhaps we can lower the light or you can see well the image. Well, patient, well, this, you can see here the stent, okay. I don't know why this is not moving. The second. Yes. Yeah. Okay. And the finding that caught the attention of the operator was this image inside the stent with this flu image. Okay. Can you please, the next slide, please. Can you put me next slide? Thank you. Well, the operator decided to perform intracoronary imaging, so he performed OCT, and you can see how the stent is a bit underexpanded, at least in the distal part. The diameter is in the distal part 2.5, 2.8 more or less, and this area was the area with the lowest minimum luminal area with 4 millimeter square. Sorry. So the operator thought that here there was a fracture of the stent. I must say that I don't see very well the fracture, but he decided that there was severe calcification. I can't stop, so it has to begin when it reaches the end. So there was, as you can see, there was severe calcification of all the LAD, and this image of underexpansion and distortion of the stent. So it was decided. This was the main findings. This was the point with the minimal luminal area and a slight mild proliferation inside the stent. Okay. So the operator decided that as the LED was so heavily calcified, he was going to schedule a second procedure to perform lithotripsy in this part, in the distal part of the stent. I don't know if you consider this was a good option, or probably the only two options the operator had was a non-compliant balloon or intravascular lithotripsy. And at least this is what the EuroPCR new algorithm recommends us when we have so heavy calcification of the vessel. So the patient came back to the cath lab for a second procedure. IVL was performed with a 312 balloon it was applied to 80 pulses, and this was the result after the IVL. You can see the image is quite good. And he performed again, as Bernardo suggested, OCT after the IVL to see if lesion preparation was good enough to implant the stent. In fact, I must say that I don't see a clearly improvement of the area. Also, I must say that I can see fractures, but I don't know if it is because of the shadow of the struts of the stent or not. But it was considered that preparation was enough, and it was implanted a second stent intrastent. And these are my concerns when I have seen this case. I don't know if it is mandatory or not to perform non-compliant balloon dilatation. We can discuss after the case. If it is mandatory or not to perform non-compliant balloon dilatation after IVL before stent implantation, or if we can assume that the therapy has been effective if there is no under expansion of the IVL catheter, or you consider if it is mandatory or not to perform OCT after the IVL. And also, I have the doubt, is it possible to see calcium fractures behind the stent? And also, although we cannot see fractures, we know from CT that there are microfractures. So is it necessary or mandatory to perform OCT after IVL? We can discuss if you want after the case. Well, we implanted, or the operator implanted a Science 312 stent, intrastent, and this was the result. He performed again OCT, and there is only this image after the implant of the stent, because if you remember, the patient had renal insufficiency, so the operator didn't want to administer a lot of dye. Well, this was the result after the stent. I think the result was quite good. The expansion is good, the position also, and the minimal luminal area post-stent was 6.4 millimeters square. Okay, so the problem was that during the angiographies to see the final result, the operator realizes that there was a stenosis at the ostium of the LAD. Yeah. So, yeah. But they didn't see at the first OCT because there was. They were concentrated on the. They were concentrated, and also because the was out of the blood was not good, so, and this part of the artery was not seen in the first OCT pullback in the first procedure, so they didn't realize.
I saw an image of 3.99. Oh, sorry to interrupt, but it's more.
Yeah.
This is very didactical, so it's very interesting. Mm-hmm. And hopefully in the end they did recognize it. But in the first OCT run, there is an area of 3.99, it seems to me, at the ostium of the LAD.
3.99 was inside the stent.
It was inside the stent.
Because the problem was that there was blood in this part, so really they couldn't see this image on the
angiography.
On the angiography it was present also, but they thought it was a moderate lesion, and they didn't see it on the pullback of the OCT because there was blood in this part. So they realized this at the end of the procedure, but the problem was that this was the calcium nodule with an area of 2 millimeters square. The problem was that by that moment, the patient had been administered 180 milliliters of dye, 1 hour, 30 minutes of procedure. Creatinine was 4.1 before beginning the procedure, and he was a kidney transplant patient. And so what would you have done? Would you have continued with the procedure?
Let's ask the panel, what would you do?
Stage procedures. I will wait for the second procedure. Maybe it's very challenging.
All of you would stage the procedure. Okay. I think
strangulation, some calcified nodule, and probably in this patient we spend 44 or 28 hours to do a second procedure.
I continue with the procedure with Hotel's LED.
For sure, the transplant is not functioning very well, so that I
What?
think
Sorry?
it is not an issue.
Sorry?
Transplant is not functioning very well.
it's not
so
functioning. He had.
Yeah, but
that
angiography
wouldn't be
is still important.
An issue for me if that was the baseline kidney function. But I think that 1.5 hours, the cardiac function, the patient.
Yeah, but I agree. But the angiography was very, demanding. I would not leave the patient coming back to the ward.
One issue that you brought that I think is very important, and thank you for bringing it up, is dilatation, high pressure dilatation after IVL. We always do, because there are some fractures that are not complete, and with high pressure you really improve the work. But in this case, in my hospital, I would not. We don't use IVL routinely.
We neither.
No, because it's very expensive.
Yeah.
So I would first try with the high pressure balloon. Many times works. If the high pressure doesn't work, we try with cutting balloon high pressure. And if it doesn't work, we use IVL. Because nothing wrong with IVL, but it costs 3,000 euro. And the other point for high creatinine, we are doing a randomized study. We have only preliminary data, but we use standard angiography, or we start, if we do PCI from the very beginning, with a guideliner. And if you go directly in the target vessel LAD, you can really do the job with 1/3 of the dye. Because you don't inject in the cusp, you don't inject in the circ. You can do a case even complex with 40, 30 cc.
Not if you have a lesion in ostial LAD, of course.
Yeah.
Guideliner, I mean. Would anyone have...
You stop in the left main, you go a little bit...
But as a general comment, I agree, you can reduce.
Then you come back, or you don't leave it there. But every time you inject, you go with a guideliner and you inject 3-4 cc.
Would anyone have used a 3.5 IVL balloon in this case? Not a 3.0
Theoretically, you have to use 1-to-1 ratio, isn't it? Yeah.
But as it's under expansion of a stent, or perhaps you don't have...
You crack the calcium, and then, as Antonio said, you use a non-compliant balloon, then you can use a 3.5.
No, I mean the IVL at 3.5, just to be sure that you are contacting all the vessel wall. Perhaps because 3.0, sometimes you feel that it's not large enough in LAD.
They size it according to the usage.
Yeah.
It's not an active lesion, it's an instant lesion. So perhaps in these cases you can overspan a little bit, just to be sure that you are contacting well. Just as a comment.
So what did you do?
Well, the operator decided to discuss these patients are managed by cardiac failure doctors. So they discussed the patient with his treatment doctor, and they decided to have conservative management. So the patient came to the clinical ward, and he had pulmonary edema requiring admission to the coronary unit. He had good evolution with resolution of the pulmonary edema. The creatinine rose to 6.75, and they performed a new transthoracic echo, because the last the patient had was 2018, and they discovered that the patient also had left ventricular dysfunction. So given the absence of refractory angina and renal failure post ICP, they decided to wait and to have a conservative treatment. They upgraded the patient to cardiac resynchronization therapy on December 2021, But on March 2022, the patient was admitted again for heart failure, and the nephrology department asked for re-evaluation of the patient. So, by this moment, the patient had chronic heart failure class 3, angina when walking. So, they thought that the patient had heart failure of multifactorial origin, and they decided to take again the patient to the cath lab. So, in this third procedure, the patient had no radial pulses, so they tried to go by the femoral artery. I suppose that they didn't remember he had occluded the right femoral artery, so they in the end had to go by the left femoral artery. And this was the initial image, the calcium nodule. And how would you have treated this nodule calcium lesion?
How was the creatinine at this time?
The same, 4.5.
Okay.
This is his basal
Pan, what did you do?
creatinine.
Intravascular nitrogen.
It's recorded.
Probably we make a predilatation with a non-compliant balloon, and if you can cross the lesion with an IVL, make the several pulls with IVL. And after that, depending on the result, probably we treat it with a drug-eluting stent from the left main to the proximal LAD.
Yeah, I probably would have also, sorry.
Same strategy.
Yeah.
You have already crossed a little, an IVL, so
Yeah.
I suppose you can. Perhaps here I will go for a 3.5 balloon, perhaps.
Yeah, or even higher. Yeah. But the operator, I don't know which was the reason, but the operator performed it in a more simple way, probably because he didn't know that this patient was coming to the cath lab that day, and we don't have this device on the cath lab. So he performed it on a more simple way. He pre-dilated with non-compliant balloon, 2.0, 3.0. Also, he treated the mid-LAD because, if you remember, there was severe calcification and areas around 4 or 3.8. He implanted Megatron stent 3.532 till the other stent, and the LAD was post-dilated with a 3.5 millimeter non-compliant balloon and 4.5 for the left main. The result was evaluated with IBUS. This was the IBUS he performed. I'm sorry because it's a bit long, but you can see how the stent is quite well apposed and expanded, and only there was a mild malapposition at the proximal part of the left main, which you can see. You can see here the malapposition, not very important, but he decided to post-dilate again with a 5.0 non-compliant balloon and to cross to the left circumflex and open the struts with a 2.0 balloon. And this was the final result. I think it's a good result also. And it was checked again with the IBUS, and the slight malapposition disappeared with this 4.0 dilation. So, just 1 second, because the malapposition really was disappeared.
More than the malapposition that is there was also an under-expansion of the stent in
Yeah,
the ostium of
in
the
the-
LAD. There was an oval
Yeah.
shape, which is now is much better after
Yeah.
post-dilatation.
Yeah. So,
Bernardo, with a lesion like this, would you even have considered to use a DCB, or would you say these type of lesions are absolutely not area for DCB?
Well, the case that I presented just before you came was similar. It was an ostium of the LAD with a calcific lesion.
Lot of calcium, left main, proximal LAD, 3.5.
I would have prepared it with probably the shockwave and then assess. Good lesion preparation, DCB. Yes. In this case, yes. Because we have already had, a stent, an under-expanded and then a restenotic stent, so we already had this experience with this patient. So I think I would have used the DCB.
It's amazing how beautiful is the result of the stent, well expanded.
This has
very nice case.
Yeah, my main take-home message is probably that intracoronary imaging is mandatory for complex calcified lesion, not only for pre-procedural planning, as you said, but also to guarantee a good result.
Step by step.
Yeah.
So please.
I think perhaps it is more important here the IBUS, the final, not to do the pot with a 4.0, but what I feel is when you don't do IBUS, you try to. I would have done pot every time with at least a 4.0. IBUS would say us if you have to go to 4.5 or even to 5.0. I think that's the point of IBUS. Not that you have to do pot with a larger balloon than the stent, no, but you have to go even larger, perhaps.
Yes. Okay, thank you.
Thank you.
So we always keep learning. So regarding the comment by Antonio, we did a small series in those cases where you try to do OCT, and you get a poor engagement of the guiding catheter in the osteo, and you suffer to get contrast into the guideliner are beautiful to get good OCT images. This is one thing. Now the other thing is the case from David. I mean, you don't need in medicine to do a randomized trial for everything, because we sometimes need to be convinced. I mean, the case of David, you fail with everything, and just in that case, he was able to prove just lithotripsy was good for bailout. In case everything fails, it's good. And this was again a beautiful case because, we tried to see calcifying stent restenosis. Lithotripsy was not, the result was not excellent, and then when we failed to recognize the proximal calcified nodule, even though this calcified nodule is with the poorest features, as Alice published in the issue of JAK intervention, that these calcified nodules are the worst for every therapy, just a conventional therapy, obtain a reasonable result. I mean, not excellent, not perfect, under expansion, but beautiful result at the end, just with plain balloon angioplasty and high pressure balloon. So that will be my final remarks here.
So panel, other questions, other points, comments? Adnan, tell us something. Shall we go with the closure?
I'm busy with the picture here because you need more time to realize this than to do the intervention. This is fine.
It's too long. Too long.
You need the big screen and
easier pictures.
I think people just make pictures
don't
never
start
work in
to
the camera.
Yeah. Antonio said that this is too complex picture to be adopted in a routine everyday life, and I agree with him. So Fernando, I think we close. You would say, Antonio, use this.
You can make a more simple picture. Let's say, how would you do? You have a calcified lesion. You cross with a wire. You see a lot of calcium on X-ray. So you know that there is calcium. What is the next step? The first step, imaging.
It's a question. Not everywhere. I don't think you have said it. You have
the mic.
This. I think that there is a lot of speculation with guidance.
Yeah.
But to be guided, you need some evidence. You have said it. You find A, and to do B. What is the evidence there? So this guidance is overestimated.
Yeah, it's over. I agree.
Yeah.
So
for me, first of all, we are also obliged by financial constraints there because OCT is not reimbursed in Germany if there is a complex lesion. If you do a simple lesion with OCT, you get reimbursed. This is the paradox there. And if you do a complex lesion, you get the maximum for the complex, and OCT doesn't add anything. The same for IVL, the same for everything. And so this is the problem with OCT not being done in every case. For this case, what you have mentioned,
let's
high pressure.
Ideally,
Yeah.
if reimbursement is for everything,
No. I wouldn't say.
what
I
would you do?
Try with the first balloon.
First balloon,
First a
non-compliant
high-
balloon.
Yes.
Appropriate size or small?
First of all, small.
Small.
Yeah.
And balloon
Because
inflates.
you see, if it is sometimes with a 2 millimeter balloon, you see that it doesn't go up. Yeah.
So if the balloon goes up, you
Because
continue with
it's
balloon.
the pressure that opens the artery.
If balloon goes up, you continue with
Yeah, we can
balloon.
continue. I go up with a larger balloon.
So you always try with the balloon first.
First of all.
If the balloon does not cross, what do you do?
Then you don't need a study for that. Because
You
it-
do
for
go
uncrossable-
rotablation.
It's a rotablation. You don't need no cardiac surgery.
So
rotablation.
the algorithm is relatively...
But the problem with the task force is that there are 20 people in the task force, and everyone tries to add something there.
Yeah.
That's very brilliant.
But
I have to add something to what Adnan said.
So let me, I mean, tomorrow we won't be dealing with calcified lesions, right? Tomorrow, so this is the time to criticize this very complex algorithm. We got Adnan here, we got Bernardo here, we got Antonio here. So let's do our own algorithm. So I will follow Antonio. So we cross with a wire, then we try a balloon. If the balloon is not crossing, we go for rota. We agree with that. If the balloon is crossing, we go for a non-compliant small, trying to be prudent and cautious. So, Antonio, keep going.
Wait.
If the balloon...
We don't have an agreement at the beginning.
If the balloon crosses, you go finally with the appropriate size balloon. The appropriate size balloon inflates very well. Case finished.
With the balloon? Popa?
Balloon. No, balloon, you implant a stent or DCB,
Yeah.
whatever,
But wait
whatever
a
you
second.
like.
Wait a second. Let's come back a little bit. We have also to be didactical.
Yeah, but
because you three together did 40,000
No,
PCIs.
but even...
But if there is people that do 100 PCI per year and have done 300 in their
But
experience,
it's the same.
they don't know what type of balloon using.
No,
Imaging
they
is
use,
important.
They use a non-compliant balloon and they go to high pressure. If the balloon inflates well in two projections, you implant a stent or you do DCB.
So 0% imaging in this type of lesions? 0%?
Let's talk later about imaging. Or maybe if you want, you do imaging at the end, after stenting or after DC or before
when it's too
DCB.
late.
No, it's not too late. It's not too late. Why you cannot do lithotripsy after high pressure balloon? If you
Off-label.
If you have a
No, after stent is off-label. We do
if you don't have a good result, you go with lithotripsy, and you can still do lithotripsy after. So, but let's say that the balloon inflates well, so you implant a stent or do DCB. The balloon does not inflate well, so then you have the choice. You do lithotripsy, or you try with OPN, very high pressure balloon, or we try with cutting balloon high pressure. We'll have high cut. I always use a lot cutting balloon 20 atmosphere, high pressure. But that's my idiosyncrasy.
Do you have ruptures?
No. If I don't oversize. But so if with this strategy you have a good expansion, you don't do. Otherwise you do lithotripsy. So I think the algorithm can be seen. And before implanting a stent, I believe it's appropriate to do IVUS if you want, to check that you reach a good lumen. But otherwise, you can implant the stent and do IVUS after, because...
The problem with good lumen after balloon angioplasty is not the truth, because there is a recoil. You have to see the balloon. If it goes up in the size of the vessel, you have risk.
Yeah, one limitation, and people, and I like Fernando to give his impression. when you see the balloon fully inflated, are we really sure that the lesion is fully dilated? Because if you have a little bit of nodule or something, in angiography, the balloon will look inflated.
Move the side.
Doesn't move the side. You know.
It goes back even with stand.
You see the balloon. You don't see the balloon cut like a salami. Then you see a half moon, but you see the projection of the balloon. So the balloon may look fully inflated, but it's not fully inflated. We have done 30 years ago a study published in an obscure journal on peripheral. We took peripheral balloons and put the IVUS core. You take the IVUS, you dismantle the IVUS, and you just get the IVUS core. The IVUS core is 18, and you can put it inside an over-the-wire balloon. And you can inflate the balloon and see at the same time the cut like a salami. And we have published that even if the balloon is on angiography fully inflated, there are areas in the balloon that are not completely inflated. And this may be an argument why to do more lithotripsy. Because many people say, I saw balloon fully inflated. I implanted a stent, the result was so and so. I saw the balloon fully inflated. I did lithotripsy, I implanted a stent, and the result was better.
So, Fernando, I have a question for you.
No, let me just
first.
So, with all these strategies saying that you should always use intracoronary imaging that is calcium. I mean, sometimes you don't need it. I mean, sometimes you just see the calcium angiographically, and if there is a heavy calcification, you know there is going to be a problem. In other times you just see a clear waste in the balloon. If there is a waste in the balloon, you don't need to, I mean, there is a waste in the balloon, and you need to go to the next step, as Antonio was explaining. I think this is clear. Regarding the inflated balloon in two orthogonal projections, I mean, this is quite reassuring, but I do agree that in some cases then you do IVUS or OCT and there is still under expansion. So you need to take care of that. At the end, I think intracoronary imaging should be used if you want to optimize the result. But in the middle, there are many cases where you already see a waste in your balloon, and you don't need IVUS to see that something is going wrong. I mean, you just need to decide if you go to very high pressure or use lithotripsy or stop, because stopping is also a possibility. And I think this is quite important to remember. I don't think, and the other issue is that all these algorithms are based on, if you got eccentric calcium, cutting is not going to do anything. If you go lithotripsy, I mean, this is very attractive pathophysiologically, but there is no data. There is no data to support any of those arrows and any of those changes in strategy. So this is quite appealing, but I mean, this is very complex and there is no data apart of being a very attractive algorithm. This is my understanding.
So there is an important role, in your opinion, on the use of imaging, not in the preliminary phases, but in the intermediate ones, and in the final, okay, I'm making this. And this is also my point. Imaging is crucial. Okay, maybe not in the initial phases, in the intermediate ones, before designing the final treatment and also the sizing, and if you put a stent also, not in case of DCB, to see if you have obtained a good result, talking about highly calcific lesions. Do you agree with this or not?
My only concern is that if you do IVUS or OCT better in the intermediate phase, of course you get new information. You see a huge calcified nodule. You see deep calcium, you see superficial calcium. The problem to me is that we don't have the data to use this information to guide our strategy. We don't have, so at the end of this is quite logical, but we don't have this data yet.
Okay, we don't have data, we will never have, probably, but we may decide if to use a stent or not, and also the sizing of the stent if we decide to use a stent.
One practical tip has never been published is when you inflate the balloon at high pressure, if you see that the markers of the balloon are all pushed on one side and the balloon is inflated in one direction and there is only dye on top and nothing below the markers, this means that there is something wrong. You have to work more. It's not well dilated, even if the balloon is fully inflated.
So finish your algorithm.
So, but my algorithm is still uncertain because when I see results after liberal lithotripsy, I become less convinced that high pressure balloon is enough. So I'm still working on the algorithm.
Okay, so close, too close.
You are the boss, please, Fernando.
No, I mean, I think after this, perhaps with some drinks tonight, we can, refine our algorithm and send a letter to the editor saying that we don't agree.
Fernando, I have other arguments for tonight, if you don't mind.
Okay, so thank you everybody, and tomorrow we got the big meeting, so thank you for coming.